So hello everybody, in this video I'll be talking regarding the various TNM classifications starting from thyroid, breast to GIT to genitourinary tract. So I'll be covering the important TNM classifications. So the first is thyroid cancer. So thyroid cancer 8th AJCC classification has some changes. Now we'll start with the T staging, that is it is starting with the size of less than 2 centimeter. So it is divided into two, that is T1A and T1B. So if it is less than 1 centimeter, it is T1A. If it is between 1 to 2 centimeter, it is T1B. Now if it is between 2 to 4, it is T2. If it is greater than 4 but limited to thyroid, it is T4A. That is intrathyroidal. Now if it extends into the strap muscles, only the strap muscles like sternothyroid, thyrohyoid, omohyoid, then it is T3B. Now, if there is a gross extrathyroidal extension, it becomes T4, in which T4A is the structures which you can resect, that is like larynx, trachea, esophagus, recurrent laryngeal nerve, and T4B that includes the prevertebral fascia like carotid artery, mediastinal vessels, which you cannot resect. So that is T4B. So T1 is less than 2 centimeter intrathyroidal, T2 is 2 to 4 centimeter intrathyroidal, T3A is greater than 4 centimeter but intrathyroidal, and T3B is greater than 4 centimeter with strap muscle involvement. T4A is involvement of like surrounding structures, T4B is involvement of carotid artery and the prevertebral fascia. Coming to the lymph node, if lymph nodes there is no metastasis into the lymph node, it is N0, in which N0A is only having cytologically or histologically confirmed lymph node, that is one or more, and N0B that there is no radiological or clinical evidence. Now if there is an lymph node invasion into the level 6 or 7, that is a pretracheal, paratracheal and the prelaryngeal or delphian lymph nodes, that is N1A, and if it goes beyond that to the other cervical lymph node station, that is 1 to 5, then it becomes N1B. So N0 is no metastasis, N1A is 6 or 7, N1B is level 1 to 5. Pretty straightforward, so don't get confused in this. So next is the classifications for medullary carcinoma, but almost there is no difference between both of them. They are both similar. So just try to remember this for thyroid cancer. Now coming to GI cancers, I'll just cover like esophagus and stomach together, then I'll cover breast, and then I'll cover the other cancers so that you did not get confused with them. Now remember, esophagus and stomach cancer almost have similar TNM staging. So what is it? So if you see TIS, that is a high grade dysplasia that is limited to the basement membrane. Now if it spreads into the lamina propria or the muscularis mucosa or submucosa, it is T1. So if it is limited to the mucosa, that is either lamina propria or muscularis mucosa, then it is T1A. If it is entering into submucosa, it is T1B. If it is entering into muscularis, that is T2. Now as esophagus does not have a adventitia serosa, so if it is invading into adventitia, it is T3. Now if it goes beyond the adventitia into the surrounding structures, now first which we can resect it, that is like pleura, pericardial, azygous vein, diaphragm and peritoneum, that is T4A, and unresectable structures like aorta, vertebral body or area, then becomes T4B. Lymph node stations, if involvement of 1 or 2, that is N1, if 3 to 6, that is N2, and 7 or more, that is N3. An important point I would like you to remember that the number of lymph nodes resected according to the NCCN guidelines for esophageal cancer is 15. So don't get confused in this. This is the number of lymph nodes which should be biopsied or should be in the resected specimen. Now coming to gastric cancer or stomach cancer, almost similar, that is if it is limited to the lamina propria without invading into it, there is a high grade dysplasia, then it is a TIS. Now if it enters into lamina propria or muscularis mucosa, it is T1A. If it is entered into submucosa, it is T1B. If it is entering into muscularis propria, it is T2. Now after this, as the stomach has serosa, if it is entering or invading into the subserosal connective tissue, without invasion of the surrounding adjacent structures, then it is T3. Now, if it enters into or invades into the surrounding structures, what structures are included? So that includes spleen, transverse colon, diaphragm, pancreas, the abdominal wall, the kidneys, the adrenals, the intestine, the retroperitoneum. All of this around the stomach, it invades into any of these organs, then it becomes T4B. If it invades only the serosa, that is a visceral peritoneum over the stomach, then it is T4A. And if it enters or invades into this organs, then it becomes T4B. Now coming to lymph nodes, N1 is 1 to 2, that is similar to esophagus. 3 to 6, that is similar to esophagus. N3 only, it is divided into 2, that is it is 7 to 15 or greater than 16, that is N3A and N3B. Now, the number of lymph nodes which should be resected in cases of stomach or gastric carcinoma is 16. In esophagus, it was 15. In stomach, it is 16 according to the recent NCCN guidelines. Coming to breast cancer, this is very important and a very frequently asked question from the TNM of breast cancer. So starting the first, the TIS or the ductal carcinoma in situ, that is classified as TIS. So TIS is DCIS, that is ductal carcinoma in situ. If there is involvement of the nipple by Paget's disease but not associated with any kind of carcinoma or carcinoma in situ, then it is termed as TIS Paget's disease. Now, if there is a breast mass which is less than 2 centimeters, that is T1. In that, if it is less than 1 millimeter, it is T1MI, that is the micro tumors. T1A is 1 mm to 5 mm. T1B is 5 to 10 mm and T1C is 10 to 20 mm. If it is 2 to 5 centimeter, then it is T2. If it is greater than 5 centimeter, then it is T3. If it is more than that size and it invades into the chest wall, not only the pectoralis muscle, because if only pectoralis muscle is involved, then it is not termed as T4. There should be associated chest wall invasion, then it is T4A. If it goes into the skin and causes ulceration or nodules or pure orange appearance, which does not meet the inflammatory criteria or inflammatory carcinoma criteria, it is T4B. And if T4A, T4B both, that is invasion into the pectoralis and chest wall and the skin is present, then it is T4C, and inflammatory carcinoma is classified as T4D. So this is again very important to remember. Coming to the lymph node or the end staging, so clinical and pathological both are different. So if there is no lymph node, then it is N0, that is either by imaging or clinical. If by imaging or clinical there is a lymph node metastasis to ipsilateral level 1 and 2 lymph node with micrometastasis, that is 200 cells or larger than 2.2 mm, but not more than 2 mm. So if the micrometastasis is present, that is 200 cells or the size of between 0.2 to 2 mm, it is N1MI. Or only if there are clinically detected lymph nodes to ipsilateral axillary lymph node stations 1 and 2, then it is N1. Now if it becomes fixed or matted in the axillary lymph node station 1 and 2, it is becoming N2A. And if it spreads to the internal mammary lymph nodes, then it is N2B. So N1 is only the axillary lymph node station 1 2 involvement, they are mobile. If it becomes fixed, then it is N2A. If they spread to the internal mammary, then it is N2B. So this is regarding the N1 and N2. Now coming to N3. So now coming to N3, If there is spread to the infraclavicular, it is N3A. If it is spreading to infraclavicular plus axillary, it is N3B. And if it is spreading to the supraclavicular, then it is N3C. So N3A is infraclavicular. If associated with that, it is spreading to the ipsilateral axillary lymph node and also the internal mammary lymph nodes, then it is N3B. And if it's spreading to the supraclavicular lymph node, then it is N3C. Now coming to gallbladder cancer, so very easy classification for you all to remember. So starting with, if it is limited to the lamina propria or muscularis, it is, we all know gallbladder does not have any submucosa. So if it is limited to lamina propria or only muscularis layer, then it is T1. If it is in lamina propria, then it is T1A. If muscularis, then it is T1B. Now if it invades beyond the perimuscular connective tissue and it spreads on the peritoneal side, but serosa is not involved, then it is T2A. But if it goes into the hepatic side without involvement of the serosa, then it is T2B. Now if it invades beyond the serosa and it invades into the adjacent organs like stomach, duodenum, colon, pancreas, omentum, or it goes into the liver after invasion of the serosa, then it is T3. And if it invades into the hepatic artery or portal vein or extrahepatic organs, but that should be 2 or more, then it is T4. But if it's a single organ involvement, then it is usually not T4, but it should be 2 or more organs with invasion into the hepatic artery or the portal vein. And in lymph node metastasis, N1 is 1 to 3 and greater than 4 is N2. So this is regarding the TNM staging for gallbladder carcinoma. Remember, there is no submucosa. And remember, regarding difference between T2, T3, T2 is the perimuscular connective tissue, T3 is invasion into the serosa, and T4 is into the vasculature. Now coming to colon, now remember colon and rectum again are almost having a similar type of TNM staging. So starting with the colon, if it is intramucosal, that is limited to the lamina propria only, like stomach, that is TIS, that is high grade dysplasia limited to the lamina propria without invasion into the muscularis mucosa, that is TIS. If it involves the submucosa, that is T1. So submucosa is T1. If it invades into the muscularis propria, it is T2. Then after muscularis mucosa, if it invades into the colorectal tissues, it is T3. So remember, submucosa is T1, muscular is T2, pericolorectal is T3. For any gastric cancers, remember that usually submucosa invasion is T1, muscular is T2, T3 is usually either adventitia, subserosal connective tissue or the pericolorectal connective tissue like this. And more than that, after the pericolorectal tissue, if it goes into either invasion into the peritoneum, that is a visceral peritoneum, or the adjacent organs, then it becomes T4. Now if it invades into the visceral peritoneum, that means that there is a bowel perforation. So what does it mean? So either there is a bowel perforation or the continuous wall of the colon is involved, that is continuous wall invasion is present, then it is T4A. And if it invades or it is adherent to adjacent organs, then it becomes T4B. That is an important point of differentiation. Coming to lymph node stations, if 1 to 3 lymph node stations are involved, that is either 1 is involved, that is N1A, 2 or 3 are involved, that is N1B. Now if there is no regional lymph node positivity but the tumor deposits are seen, so remember that tumor deposits, if they're given and they are seen in the subserosa, mesentery or non-peritonealized pericolic and perirectal tissue. Remember this, don't get confused with this line, like what does it mean? It is related to the end staging. So if there are tumor deposits which is limited to subserosa, mesentery and non-peritonealized pericolic and perirectal tissue, then it is N1C. 1 lymph node N1A, 2 or 3 lymph nodes, N1B. No regional lymph node but tumor deposits on serosa, mesentery and non-peritonealized tissue, that is N1C. If 4 or 6, that is N2A, and 7 or more is N2B. Now in metastasis, in this it is important to understand M1 is divided into M1A, M1B and M1C. So if it is limited to one site, it is M1A. If it is 2 or more site, it is M1B, and there should not be any peritoneal metastasis, because if peritoneal metastasis occurs, then it is M1C. So that is important for colon cancer. And what is the lymph node, amount of lymph node which are required for colon cancer? So 12 lymph nodes are required to be biopsied during colonic surgery according to the recent NCCN guidelines. Coming to rectal cancer, so almost it is similar to colon cancer, that is T1S is intramucosal, T1 is submucosa, T2 is muscularis, T3 is pericolorectal tissue, T4A is invasion through the visceral peritoneum, that is there is bowel perforation or continuous wall invasion. If it is adherent to invading other organs, that is T4B. Lymph node stations, N1A, 1 lymph node, N1B, 2 or 3 lymph nodes, N1C, no lymph nodes but tumor deposits in serosa, mesentery and non-peritonealized tissue, and N2, that is 4 or 6, N2A, and 7 or more, N2B. And again same metastasis, 1, 2 or more without peritoneal mets, M1, M1A, M1B, and M1C is with peritoneal metastasis. Coming to anal canal carcinoma, so if it is limited to the intraepithelial lesions, that is HSIL, that is Bowen's disease, or anal intraepithelial neoplasms type 2 or 3, then it is TIS. If it is less than 2 cm, T1, 2 to 5 cm, T2, greater than 5 cm, T3, and if it invades into other organs around the anus, that is vagina, urethra, bladder, then it is T4. And in lymph nodes, if it is into the inguinal, mesorectal, internal iliac, it is N1A. If it is into the external iliac, it is N1B. And if it goes into the external iliac with any of the N1A lymph node, then it becomes N1C. So this is regarding the anal canal carcinoma TNM staging. Now coming to the biliary tumor, so first is the intrahepatic. So now intrahepatic, it is basically related to the size and also associated vascular invasion. So if it is less than 5 cm without vascular invasion or greater than 5 cm without vascular invasion, that is T1A and T1B. If it is having intrahepatic vascular invasion or having multiple tumors, then it is T2. If they invade the visceral peritoneum, then it's T3. And if it is invading into the extrahepatic structures, then it is T4. And if they have lymph nodes or don't have lymph nodes, that is N0 and N1. So any intrahepatic bile duct tumors basically divided into T1, that is less than 5 cm or greater than 5 cm without any vascular invasion. If they have vascular invasion, then it is T2 or multiple tumors. In T1, it was a solitary tumor. If it has intrahepatic vascular invasion with visceral peritoneum is invaded, that is T3, and T4 is extrahepatic spread. So this is regarding the intrahepatic bile duct cancers, and if they have lymph node metastasis, it is N1. Now coming to perihilar, so in the region of hilum, it is depending on the wall of the bile duct, how much it is invaded and how much the adjacent structures are invaded. So if it is limited to the bile duct and limited to the muscularis layer, then it is T1. Now if they extend beyond the wall of the duct into the surrounding tissue, that is the adipose tissue, then it is T2A. And if it is spreading into the liver or hepatic parenchyma, then it is T2B. If it is invading into the portal vein or hepatic artery, then it is T3. And if it is invading into the usually like the second order biliary radicals or portal vein branches or the hepatic artery involvement on the contralateral side, in which case it becomes unresectable, then it is T4. Now lymph node, if it is 1, 2, 3, it is N1. If it is 4 or more, that is N2. So in intrahepatic, it was basis of size and the vascular invasion. In perihilar, it is depending on the layer involved and the spread. So if it is into the muscularis, T1. If into the adipose tissue around the duct, T2A. If into hepatic parenchyma, T2B. If unilateral side hepatic arterial portal vein involvement, that is T3. If contralateral side involvement or secondary order biliary radicals involvement, then it is T4. And if 1 or 3 lymph node, it is N1. If 4 or more lymph nodes, then it is N2. Now coming to the distal bile duct cancer. So now there are not much structures around it except for the vasculature. So it now in this invasion depends on the depth. So if it is less than 5 mm, it is T1. If between 5 to 12 mm, it is T2. If greater than 12 mm, that is T3. And if it is invading into, as I told, the vasculature, that is SMA, common hepatic artery or the celiac trunk, then it is T4. And like the intrahepatic or the perihilar bile duct tumors, if there is 1 to 3 lymph node, that is N1, and 4 or more is N2. So this is for the distal bile duct cancers. Coming to the HCC, it does not have a TNM classification, but definitely we have the BCLC classification or the staging. So accordingly, it is divided into very early stage, early, intermediate, advanced, and terminal stage. This is a very important classification. So if there is a single mass which is less than 2 centimeters, or it is a carcinoma in situ, so it is a single tumor, and we have to see if the patient is candidate for liver transplantation or not. If the candidate is not a candidate for a liver transplant, then we should go for ablation, because in that case the patient will not be amenable to resection also. But if we think that the patient can be a potential candidate for transplantation, we check for the portal pressure and bilirubin. Now if the portal pressure and bilirubin are normal, then we can go for resection in that patients. That means that we can do with surgery in form of resection. But if the patient has abnormal portal pressures or bilirubin, that means there is a changes of cirrhosis and chronic liver disease, then in that case we see if the patient has any associated diseases which may be a contradiction for transplantation. Now if there is no contradiction for transplantation, we go for transplant. So this is from Shackelford and this from Bloomgard, but this HCC, BCLC is accordingly stage and treatment modalities are given in Sabiston. So I have covered this so that it is easy for you to remember if any question is asked from this. Now coming to the early stage, so if there is a single tumor which is usually around 3 centimeters, or there are 3 nodules each less than 3 centimeters that is coming under the Milan criteria, then we see that if the patient is contradiction to transplant or is a candidate for transplant, in that case, if it is a single tumor, then we check again for the portal pressure and bilirubin. If it is normal, then in that case we should go for resection. If it is increased, then we see if the patient has any associated disease. If not, we again do transplant in that case. And in cases of patient having 3 nodules or multinodular disease, we see if the patient is a contradiction to transplant or a candidate for transplant according to the associated diseases. If there is no contradiction, then we go for transplant. If yes, then we go for ablative therapies. That is by form of RFA or electrophoration. Now coming to intermediate stage, that is, it is a multinodular disease, but no portal vein thrombosis. That is multinodular, which does not come under the criteria for, according to Milan or UCSF. In that case, we go for TACE or transarterial chemoembolization. If there is a portal vein metastasis, in that case it becomes advanced stage, that is C. In that case, we go for a chemotherapy, that is form of sorafenib. And if the patient is a terminal stage, in that case we go for a palliative therapy. So very early stage is stage 0, early stage is stage A, intermediate stage is stage B, and advanced stage is stage C, and terminal is D. So this is regarding the hepatocellular carcinoma, BCLC staging. So coming to testicular cancer, so TIS is a germinal neoplasia in situ. Now if it is less than 3 centimeters, it is T1A. If it is greater than 3 centimeters, but it is limited to testes and it does not have any lymphovascular invasion, that is T1. If it spreads beyond the testes into the surrounding structures like epididymis or the tunica albuginea, and it may or may not have a lymphovascular invasion, that is T2. Or if it is limited to the testes but it is having lymphovascular invasion, that is T2. If it is spreading into somatic cord, it can or cannot have a lymphovascular invasion, it is T3. And if it is spreading outside the scrotum with or without lymphovascular invasion, that is T4. Now in lymph node, if it is spreading, having a lymph node mass that is 2 centimeters or smaller, or a multiple lymph node, but that also they should not be more than 2 centimeters, then it is N1. If there is a lymph node mass which is between 2 to 5 centimeter, or the multiple lymph nodes, again the common size should not be more than 2 to 5 centimeters, and if it is greater than 5 centimeter, then it is N3. So this is regarding the clinical lymph node staging. And if there is lymph node spread into the non-retroperitoneal or lung mets, then it is M1A, and non-pulmonary it is M1B. So if in other than retroperitoneum or into the lungs, it is M1A, and outside the lungs any extra pulmonary metastasis, that is M1B. And in this test is important point to remember is regarding the classification according to the tumor markers, that is S1, S2 and S3, and that is dependent on LDH, HCG and AFP. So if it is less than 1.5 times normal, or 1.5 to 10 times normal, or greater than 10 times normal, that is S1, S2, S3 for LDH. For HCG, if less than 5,000 to 50,000 and greater than 50,000, that is S1, S2, S3 for HCG. And for AFP, if less than 1,000, between 1 to 10,000 and greater than 10,000, that is S1, S2, S3 according to the serum markers. So this is related to the testicular cancer. Now coming to kidney cancer, very important. You must have all have read this. Now just try to concentrate on this for GUT cancer, because other than that, if you don't remember, it's fine. But in kidney, they can ask TNM classification. So it starts with first T1, that is less than 7 centimeter, that is divided into T1A and T1B, that is if it is less than 4 centimeter or between 4 to 7 centimeter. Then T2 is that is greater than 7 centimeter. Now if it is between 7 to 10 centimeters, it is T2A. If it is greater than 10 but it is limited to the kidney, it is T2. Now T3 is that it is divided into 3A, 3B and 3C. Now 3A is if it is invading into the renal vein or the branches or in the pelvic ileal system or the renal sinus fat, but it is under the Gerota's fascia, not invading beyond that, that is T3A. If it is into the IVC but below the diaphragm, and T3C is if it is IVC and above the diaphragm, or there is a invasion into the wall of the IVC, then it is T3C. And if it is invading beyond the Gerotas, then it is T4. So less than 7 centimeters, less than 10 centimeters or greater than 10 centimeter, T2A, T2B. If it is above the 10 centimeter mark, but it is invading into either the renal vein or branches or pelvic ileal system or the perirenal fat, but not invading into the Gerotas, that is T3A. If it is invading into the IVC but below the diaphragm, T3B. Above the diaphragm, T3C, or the wall of the IVC, T3C. And if it is invading beyond the Gerotas, that is T4. And if with or without lymph node, that is N0 or N1. And with or without metastasis, M0 or M1. So now coming to prostate cancer. So T staging starts with T0, that is no evidence of tumor. T1 is that the tumor is not palpable, it is clinically inapparent. So in that, on biopsy, if it is present in less than 5% of the tissue resected, that is T1A. If more than 5%, then it is T1B. And if it is identified by a needle biopsy and either of the both the lobes of the prostate gland, then it is T1C. But in all of this, the tumor is not palpable. Now, if it is palpable but it is limited to the prostate, that is T2. Now, if it is involving one side, it is T2A. If more than one side, like more than one half of one side, but not the both the sides of the prostate gland, that is T2B. If both the lobes are involved, that is T2C. Now, if after that there is extension into the extraprostatic tissue, that is either unilateral or bilateral, that is T3A. And if it is invading into the seminal vesicles that comes around it, that is T3B. Now, if beyond seminal vesicles, it is extending into either the sphincter, rectum, levator muscles or the pelvic wall, it becomes T4. And with or without regional lymph node metastasis is N0, N1. And in metastasis, if it is invading into the non-regional lymph node, M1A, bony metastasis, M1B, and other sites is M1C. Now, important point to remember is that in T1 it is an inapparent tumor, so it is depending on the tissue, how much percentage we have detected on histology. In T2 it is limited to the prostate, but either of the half side of one lobe or more than half side of one lobe, but not bilateral, that is T2B. And if both the lobes are involved, that is T2C. Extraprostatic extension, T3A. Beyond into seminal vesicles, T3B. Extending into the adjacent structures, that is T4. And pathological staging, if organ confined, that is T2. If extraprostatic extension, as you have seen here, that is into the bladder neck microscopically or unilateral bilateral just beyond the capsule, that is T3A. Again, same like the clinical T staging, and T4 is also like same like clinical staging. So this is all about the T staging of various cancers. I hope it is very much clear for you. I think that you can just go through this video for your revision of the TNM classifications and the lymph node stations, lymph node number which are needed to be resected in GI cancers. So I hope I did not make it dry for you. So thank you so much for watching.